All right, folks, now we're going to go over OB and neonate. So we'll get this going. It's not super long slides, but it is pretty lengthy. So we'll get this dived off from there. So these are considered special patients with special population patients. And that's the reason why that they are is because of their size. They everything on them functions smaller. We have to think about how the baby works, how the neonate, everything requires their heartbeat faster, their respiration drops so much more. And then when you think about when traumatic injuries happen to them, we need to recognize this. What I want you to be on the lookout for is, what is a normal delivery? Vaginal bleeding if the patient is pregnant, anatomy and physiology of a normal pregnancy, and the patho and the complications of potential all pregnancies. We'll talk about abnormal delivery. We'll have a nuclear cord. We'll have a prolapse cord, a breech delivery. If you've never had children or been able to partake into a childbirth, some of these pictures may get you. It's not like there's anything out there that's like, oh my God, what is that? But at the same time, this may not be something you're used to. So we'll talk about third trimester bleeding when we go into the abrupto placenta and the placenta previa. We'll have a little bit on here about the spontaneous abortions or miscarriages. We'll talk about the ectopic pregnancies and pre-eclampsia and eclampsia during pregnancies. And what we want you to do is talk about neonatal assessments. What's difference in the neonatal resuscitation if they come out as a neonate and not breathing. We want to talk about how do we take care of them? What do we need to do right after childbirth to make them continue to grow and sustain life? We know that one. So the national standard says talk about special consideration trauma. So what we want you to do is recognize and be able to manage, fix, document, treat, take care of pregnant patients, pediatric patients, geriatric patients, and talk about the patho and all of those, along with the connectivity and of an impaired patient. Well, what's the difference? Why do I have issues about that? So most childbirths in the United States still occur in the healthcare setting by trained people, trained medical personnel, but sometimes occasionally the pregnant woman is unable to get to the hospital, and that's where we get welcomed to the world. We get to come out there and do these deliveries that take place on the side of the road, that take place in home, those remote settings. Those are the issues that we have to worry about, and why, and just the fun parts. Excuse me, I'm trying to handle something real quick. I thought I could get going. But delivering a baby shouldn't be something that should scare you. As every delivering of a baby is not what every one of us wants to do, but at the same time, it's a very simple skill. It's something that we all can do. Here, we talk about the ovaries, or the two glands, and one on each side of the uterus, and they're similar to the function of the male testicles. Each ovary contains thousands of follicles, and each follicle contains an egg. Ovulation occurs approximately every 2 weeks prior to the menstruation. If fertilized, the egg implants in the endometrium, the lining of the inside of the uterus. And the egg, if the egg is not fertilized within 36 to 48 hours after it's been released, it will die, and the lining is shed as menstrual flow. It occurs around the 28th day of the woman's cycle. I'm sorry, y'all. Hang on one second. I apologize. We eat dinner before I come upstairs, and sometimes that random piece will get caught in my tooth and drive me insane. All right, so here we talk about the fallopian tubes. They extend out laterally from the uterus. with one tube associated for each ovary. Fertilization usually occurs when the egg is inside the fallopian tube. The fertilized egg then continues to the uterus, where if implantation occurs, it develops into an embryo, and then the fetus grows. The fetus, not fetus, sorry, grows until the time of delivery. The uterus is a muscular organ that then closes and protects the fetus. Let's see, hang on. The uterus produces contractions during labor and ultimately helps to push the fetus through the birth canal. So the birth canal is made of the vagina and the lower third of the uterus called the cervix. Here you go, here's your picture. So right in here, hang on, let me drop a light and I can see better. All right, cool. All right, so right in here is our cervix. We have our vagina, that's the birth canal at the same time, and here's our cervix. So you can imagine when ladies say they always got to pee because when they're pregnant, now you see why. Them big old heads of them babies are pressing down directly on top of the bladder. Now, that can be a good thing and a bad thing. That's the reason why when women go into labor or pre-labor, they want to empty of all the feces in here, and they want to try to have that bowel movement. And you can see as they may tinkle a little bit, and then they deliver this child and get all the placenta, and they make sure everything's delivered fun times, happy babies. All right, so the vagina is the outermost cavity of the female reproductive system and forms the lower part of the birth canal, as we talked about right here. Here, as you can see, is the vagina opening. That is the lowest opening, and it completes the passage from the uterus to the outside world for the newborn. And then it talks about the perineum being the skin between the vagina and the anus. And you can have tears here. Ladies can have severe tears between this area right in here. This area will tear. Those are very, very painful. I think it's like a 1, 2, and a 3 tear, if I'm not mistaken, 3 being the worst. All right, so here, in a pregnant woman, the breast produces milk that is carried through the small ducts to the nipple and provides nourishment to the newborns once it is done. Your screen shows early signs of pregnancies. The breasts include increased size and tenderness. Let's talk about the anatomy and the physio of female reproductive systems. So the placenta is a disc-shaped structure that is attached to the uterine wall that provides nourishment to the fetus. And it keeps the circulation from the woman's keeps the circulation of the woman and the fetus separated, but allows substances to pass between them. Anything ingested by the pregnant woman has the potential to affect the fetus. The umbilical cord connects the woman and fetus through the placenta. The umbilical vein carries oxygenated blood from the placenta to the heart of the fetus. The umbilical arteries carry deoxygenated blood from the heart of the fetus to the placenta. Now, you will also, so here in the cord, once they're delivered, you will probably hear, if you haven't already as a parent, that they want to get cord blood. So what that does is they type and match and all that, and they get vital information of the child without having to obviously put IVs in the arm, draw sorts of blood. They can get all they need from right here at the cord. They can draw all the blood they need, and it obviously matches and types to the baby. So that's where you get a lot of your information is from right there. The umbilical cord is the lifeline. It is their main source. That is the only source of food, fluid, and communication from the woman to the fetus, and that is carried through the placenta. The umbilical vein carries oxygenated blood from the placenta to the heart of the fetus. The umbilical carries majority of the deoxygenated blood from the heart to the fetus. So everything is going through it's the umbilical cord, which is a lot of things are called that in life once you move on, because that's That's the heart, the brain that holds everything to the body. Um, they use it a lot in diving. If they do fixed diving and they have all the cords running through anything, that's their umbilical cord. Sorry, just dove off on that one. All right. So the sacs contains about 500 to 1,000 milliliters of amniotic fluid. To give you an idea, so you can judge, a normal IV bag is 1,000 milliliters. And this helps insulate and protect the floating uterus when we talk about the amniotic fluid. The amniotic fluid is released in a gush when the sac ruptures. It's usually in the beginning of labor. So what that tells you is like their water's broke. That is your first sign of labor. And I'm gonna tell you, it's well worth listening to. And if a mother tells you that they've had 3 deliveries, and this is their 4th one, you might want to be ready to hurry up and catch, because they don't have no time. They don't have no pause game. They don't have no hold it. When they say he's coming, you best get ready, because she ain't lying to you. She's already been down this road, and her body is in tune with what's going on. So some normal changes in pregnant just Lord Almighty. Some normal changes in pregnancy. Rebecca says I had my 3rd one in 2.5. Yeah, so they deliver quicker and quicker each time. So they don't play around. So that's something to think about. So during pregnancy, what happens is things start happening to the female's body. I swear I'm only going to pick about my wife. I won't pick about anybody else. But it seemed like my wife lost all reality to think, to function, to do anything. She lost every bit of smarts she had, and it went to my daughter. She just couldn't like remember how to tie her shoes. It was crazy. So you're gonna notice the respiratory system. They're gonna have a whole trouble breathing on just doing normal tasks. You got to think here. The heart is being worked over, so their cardiovascular system is in strain, and their musculoskeletal system is drained, because now you have this sac of child that's pulling on their central part, their abdomen, their spine. It's pulling on. They're just not. Nothing that happens makes them feel comfortable, and it is every bit of the other spouse's fault. I don't care what you say, how you say it, it is 100% the other spouse's fault. So notice when you get these changes that the wife will compensate pretty fast because of her overload of fluid. The reproductive system, the hormone levels increase to support the fetal development and prepare the body for childbirth. That's the reason why they start carrying high in pregnancy. And then as they get further into the labor, they start dropping and they become into more of in line with the birth canal. They have to get in the position, the head has to drop. And that is just something that is known by the body so they can start delivering of this child. If this pregnant, this puts the pregnant woman in increased risk for complications for trauma, bleeding, and some medical conditions. Uterus is displaced from out of its normal, well-protected position within the pelvic area, and the increase of the change of the direct fetal injury and trauma. Let me read that again. This increases the chance of direct fetal injury and trauma because of the movement. Rapid uterine growth. So what happens here is this: in the second, third trimester, things start changing. First, second, third, the placement of the body, the movement of the child, getting ready to deliver through the birth canal. As the uterus grows, it pushes up on the diaphragm, displacing it from the normal position. So that's where you get your shortness of breath. I'm tired. And your respiratory capacity changes because now those lungs are also impacted by pressure. They have this body that is growing in them in the center part of their body, and it is just not where it's supposed to be, and they can't breathe. Everything is uncomfortable and they can't function. So their overall blood volume does gradually increase throughout the pregnancy. So what it's going to do is it's going to allow for the adequate perfusion of the uterus, prepare for the blood loss that will occur during pregnancy. Blood volume may eventually increase up to as much as 50% by the end of the pregnancy. Now, that's a lot. I mean, you think about, so if your body already, let's say, just so we can figure it out, carries 2 IV bags around a day that is full of fluid. So we're going to potentially increase that by 50%. So we're going to add another IV bag of fluid into the body for them to function, clean, work, overhaul that blood and get it back into use. The number of red blood cells also increase. The speed of clotting increases to protect against excessive bleeding during pregnancy. By the end of the pregnancy, the pregnant patient's heart rate increases up to 20% to accommodate for the increasing blood volume. So your cardiac output is significantly increased also. So that again, that goes with your respiratory drive, your heart rate's going to be up. So just normal day in, day out functions for 90% of the pregnancy women, it is going to, like, they're going to have that workload. That workload's going to increase. They're going to feel uncomfortable. They're going to have trouble breathing. You'll notice a rapid heart rate change. All those are going to take place about second to third trimester, and then you're going to have a baby shortly after. So pregnant women are at an increased risk for GI reflux, nausea and vomiting, and potential aspirations because of the change of their GI tract. So because everything's being compressed, what it's doing is not allowing that extra space, the knee, the open, it's just all being compacted by that baby. And now the mother's like, I don't know what to, so it's everything smaller in that area. That's why they're having more trouble for GI issues. So obviously we know we're going to have a weight gain because we know the blood volume is going to increase, the fluid's going to increase. Oh wait, you forgot you have a human in your body. So that's going to also impact your skeletal system, which we should expect that. Certain homes affected by the musculoskeletal system is making the joints looser and stable. In the third trimester, changes from the body center of gravity increase the risk of slip, trips, and falls. So you got to think they're not used to walking around with these bowling balls on their tummy. So now they move also. So these moving bowling balls are placed on their stomach, and they're trying everything they can to adapt, overcome, move with, and it just like does not work right. Complications. So you know that you may have high-risk pregnancies. We've all heard that some women are bedridden once they get to a certain point because they are at a higher risk. And that's noticeable. The problem is we just don't know that as we walk into a situation. And it's easy to say, so what are you a high-risk elevation? Or are you just sitting home relaxing here? I just asked so I can mentally prepare if something starts to happen, change. And at this time, they've met with the doctor so many times, they know way better than we do of their pregnancy status. I guess that's the best way to put it. I don't really know. Oxygen has always been safe to use with pregnant women. Just remember, certain gases that they may provide are not healthy because those gases also are going to go down to the baby. Diabetes, we know diabetes develops during pregnancy. For the ladies in the class, you've all had the ones that have pregnancies, you've all had the glucose test. So I've heard that's really gross. I was forced to drink it one time just because I was told, if I got to do this, so do you. All right, sure, I'm down for it. Sounds amazing. So They have to do the glucose test. They'll have to do all sorts of tests, and it's just to make sure that they understand the fetus to the most limit. They try their best to understand everything that's going on and give that baby a fair chance. Click. All right, so hypertension disorders, we know that their blood pressure is going to increase. One is because of the blood volume, and two is because of the workload. So the gastro hypertension is the presence of high blood pressure and the use of our, gastro hypertension is the presence of high blood pressure in the absence of another systemic effect, defined as a systolic blood pressure higher than 140 millimeters of mercury and has a diastolic blood pressure higher than 90. Considered severe when the systolic pressure is higher than 160 and the diastolic is higher than 110. So that is critical. When you get to a pregnant female and her blood pressures are that, she's close to having a stroke. She's probably close to having some pregnancy malfunctions and losing the child, or going to severe pregnancy distress, and she's going to need to be transported to the hospital ASAP. Pre-eclampsia, I don't want to say that doesn't happen as common as it used to be, because I know that obviously it still happens because they treat that every single time. I mean, people are sent home to, bedridden and all that to help try to prevent that. So pre-eclampsia is characterized by hypertension, severe or present hypertension. They have visual abnormalities such as seeing spots, blurred visions, are sensitive to light, swelling in the hands, feet, or edema. Let's see, upper abdominal or gastric pain, dyspnea or retroperitoneal chest pains, anxiety. You'll have an altered mental status. So these are all things that are possibly going to come from your pre-eclampsia. So now we talk about eclampsia. This is more of the worst one. This is going to result due to hypertension, but treat the seizures that's going to come along with it. You got to make sure you lay the patient down on their side and resting comfortably. Maintain their airway. That is important because we can't go back and fix something that is super duper important. If we see it, we have to address it. They have to maintain his or her airway. Administer supplemental oxygen if necessary. Provide ramp transport and call for an ALS intervention if needed. Transporting the patient on her left side can prevent the Suspine hypertensive syndrome, caused by compression of the descending aortic and the inferior vena cava by pregnant uterus when the patient lies supine. So when you lay them flat on their back, their pressures are going to increase. Their pressures are going to get through the roof, and it's very super easy to fix. You should have just laid them on their left side, or put them at a 45-degree semi-Fowlers. But if you have to put them on their side, I would put them in the left lateral recumbent position, and that position is obviously on their left side. And I say it is resting comfortably, which I guess that's just the easy word for to say. But just they turn to the left, so it's easier for you to see them in the back of the ambulance, and it gets all the pressure off of their internal organs. Let's see here. Internal bleeding may be a sign of an ectopic pregnancy. When the embryo develops outside of the uterus, most often in the fallopian tube. They say that's pretty painful. Obviously, I don't know. I've been blessed and not have to deal with that in my personal life, but they say that those are painful. Sudden onset of severe abdominal pain and vagina bleeding may be the first trimester of pregnancy, should be considered as an ectopic pregnancy until proven otherwise. Consider the possibility of ectopic pregnancy in a woman who has missed a menstrual cycle and complications of sudden severe, usually unilateral pain in the lower abdomen. Let's see here. What is this picture? So the picture is showing you where your ovaries are, your uterus, and then it's where the fallopian tube starts to develop this uterus. All right, so the sudden onset of severe abdominal pain and vaginal bleeding is in the first trimester of a pregnancy should all be considered ectopic pregnancy until you can be proven otherwise at a medical facility. Consider the possibility of an ectopic pregnancy in a woman who has missed a menstrual cycle and complains of sudden, severe, usually unilateral pain at the abdomen. Whew, that sounds like a tongue twister there. Hemorrhaging from the vagina that occurs before labor begins, may be very serious or not. Let's see here. What is this saying? The later signs of pregnancy that may indicate a abruptoplacentia, and those are painful. The placenta separates prematurely from the wall of the uterus, and it's most uncommon. Where is that at? Caused by hypertension or trauma. The placenta previa is the placenta that develops over and covers the cervix. Any bleeding from the vagina in a pregnant woman is a serious sign and should be treated promptly in the hospital. Treat for shock, obviously, if they've lost too much blood and they're trying to figure out, you got to stop it. Now, again, here, we don't pack the vagina. We just let it do its thing and we transport. Place a sterile pad on the sanitary pad over the vagina and replace it when necessary. Do not put anything into the vagina opening possibly control the bleeding. So if it's, don't pack it, don't pack the wound, let it flow, forcefully bleed, and eventually it will either coagulate with the rest of the blood or it'll stop. I don't mean stop as in a bad way, but it'll stop. So here are the figures that show the abruptoplacentia and the placenta previa. So you see this one is surrounded by all of the fluid up here. You have a placenta previa here, your abrupto is over here. Trying to think what else to add here. Here you notice the placenta is trying to come down first. That can be bad at the same time, but you need to be prepared on what to do. Abortion, spontaneous abortion is the loss of the pregnancy prior to 20 weeks of gestation, and it without any special procedures or surgical procedures to intervene. The term is often used interchangeably with miscarriages, and the induced abortion is the evidence termination of a pregnancy prior to the time frame of visibility or viability. The most serious complications are bleeding and infections. The woman is in severe in shock. Treat and transport promptly to the hospital. Bring any tissue that's passed through the vagina to the opening, and never pull the tissue out of the vagina. Let it be. Let them do all the pushing, pulling, poking, and prodding. It's not our job. It will get you in trouble. So keep open mind, but make sure you don't just walk up there like, oh, I can't do it no more. And again, if you start that way, remember, we don't want to pack it. We want to try to pat it and let it stop clotting on its own. The woman's at risk for bleeding infection if the uterus ruptures. Ooh, that's going to be nasty. Pay attention to the environment for any signs of abuse. You may notice bruising. You may notice old bruises. Look around the scene. Is he speaking for her, or is he being overly protective? And at the same time, as they may not want to leave the abusive relationship, and they're very hard and with forthcoming of information. So keep your eye out for that. It is our ability to be the voice of them, specifically if like I'll say I don't want to say the aggressor because that's probably not the best words, but if the other subject in the facility, in the room, the home, wherever you're at, and they're answering all your questions, a lot of that is signs of they don't want them to answer questions or potentially find out something that they don't need to know because the female is uh, overly forthcoming with information. Any types of substance abuse, it will affect uh, the addiction of the fetus because it's probably going to be on it for a hot minute. So you have results of that due to prematurity, low birth weight, severe respiratory distress, and in the worst case, unfortunately, is death. Fetal alcohol syndrome describes the condition of an infant born to women who have abused alcohol. So I know our med facility, they university has a med pediatric floor that has, I don't know for exact, but has several. I can just imagine has several infants on the facility that have probably that are addicted to heroin, fentanyl, and things like that. Alcohol toxicity is probably a big one too. I would say your alcohol probably comes in like your storm months, things like that, because they're not able to get out. And remember, after a woman gets certain uh, point in pregnancies, they're unable to fly anymore. So that may also be signs at that time when they are at home a lot more and they're unable to. You may see a lot of abuse in the beginning because it's her fault that she got pregnant. You're the one that didn't do this. Those are the kind of things that you have to also be very, very cautious of. If you're called to handle a delivery of an addicted woman, pay very close attention to your safety. It doesn't take two people to deliver the child. So when you get to that situation and you start doing stuff like that, have your partner just make sure to look around, see what's going on. Um, anytime that you suspect the presence of a drug paraphernalia, you can also suspect of empty wine or liquor bottles, statements made by the family or bystanders, or the patient or herself. The newborn will probably need immediate resuscitation at this point because the female is at stress and it's going to cause stress on the uterus, which is also in return going to cause issues upon the child. They're just in a position hmm, of shock, basically, and that's the reason why when you have these, they're addictions. You have very small birth weight too, obviously what we've just read, but their birth weight is going to be super, super little too. And they will get super cold on you. And that's why you want to try to put them against your chest. Let's see here. Tell you what, guys, do me a favor. Give me just a minute. I had a guy walk in the clinic real quick. So give me just a second and I will be right back. Okay. Hey y'all, tell you what, take till 7 o'clock. I'm gonna have to work this guy for just a minute. So sorry to take a break so early, but give me just a minute so I can take care of this, and I'll see y'all. Hey y'all, sorry about that. I really do apologize. But unfortunately, that's welcome back to the oil field. All right, so where were we? Here, let's go here and we'll catch up in a few minutes. All right, so pregnant women have an increased amount of overall blood volume. We know that, and by the third trimester, their heart rate is going to increase about 20% of the time, 20% of the load. A pregnant trauma patient may experience a significant amount of blood loss before you take signs of shock, and the reason why is because of their blood volume. The fetus may also have trouble before signs of shock. And the bad thing is us and EMS don't have a way to monitor the child's heart rate. We don't have the instruments that is a higher than normal, higher than planned skill that is used to monitor the heart rate. So we're not probably ever going to have that into EMS, but note that the kid's going to probably have some issues into shock before we're able to notice that. So be alert for additional concerns about ready to assess and manage unique types of injuries when responding to these pregnant trauma patients. And what I mean by is the uterus is especially vulnerable for types of penetrating trauma because of how thin and how stretched out that it is. We look for trauma in the pregnant uterus can be life-threatening to the woman, but and the fetus itself because the uterus has rich blood supply. In most cases, the only chance to save the life of the fetus is an adequate resuscitation of the woman. So that's really the only thing we can do is just in a traumatic situation is just do resuscitation of the mother because we don't really have any ways to do an in-field delivery unless it's already an active delivery. And then we potentially, even if it is an active delivery, we may be doing resuscitation on both the mother or the newborn, stillborn, because at that point we're having to max our capabilities out. So we're probably going to be requesting additional resources because the traumatic load is higher than what we are used to. So as when a pregnant woman is involved in a motor vehicle crash, be very close and paying attention to the hemorrhage. You may not see hemorrhaging on scene, or by the time you arrive there and they started to hemorrhage, think about the potential for the blood loss that is happening, or that has happened. Because if you're seeing it and it's 15, 20 minutes after the event, it's probably been going on for a while. You should also suspect an abrupto placenta when the MOI is a blunt trauma to the abdomen and the patient's sign and symptoms are suggestive of a shock. Common symptoms include vaginal bleeding and severe abdominal pain. Improper positioning of the seatbelt can result in injury of a pregnant woman and the fetus at the same time if involved in a car wreck. Let's see, what's your say? Carefully assessing of a pregnant woman's abdomen and chest for seatbelt marks and bruising for obvious trauma. If pregnant trauma patient goes into cardiac arrest, your focus is the same as with the other patients in cardiac arrest. Perform CPR, provide transport to the host hospital according to your protocols. If the woman is the last month or two of pregnancy, compressions may need to be applied a little higher than on the sternum as usual because of the placement of the child. Whoops, let's back that up. All right, that's it. All right, so your focus is the assessment and management of the woman. And because the infant is not there yet, our only focus can be on the one patient at the time. Suspect shock based on the MOI. Be prepared for vomiting and anticipate the need to suction the airway. Be aggressive at that. If you see a little bit of vomit, let's go ahead and get that out so there is no aspiration. Attempts to determine the gestational age is only going to help us to determine the size of the fetus and the position of the uterus. So if we can guesstimate and say, hey, they're 8, 9 months into there, knowing the anatomy of the body can assume and guess depending upon the wear of the placement of that child is of the uterus. So in a trauma patient, what you want to do is maintain an open and airway. So what we need you to do is, again, be prepared for vomiting, assist high flow of oxygen, ensure adequate ventilations. So if the patient's ventilations are not adequate enough, provide or assist the ventilations with the bag valve mask, and 100% of oxygen should be hooked up to the BVM. When you assess the circulation, control all external bleeding, maintain a high index suspicion of internal bleeding and shock based on their MOI. Transport the patient on her left side and call for ALS rapidly, because you're going to need extra assistance there. So cultural sensitivity is very important when you're assessing and treatment of a pregnant patient. Remember, some cultures may have that to where no man is able to touch the female, no man is able to see the female's body. They may already have that procedure planned on how they're going to do this at-home delivery or a special religious delivery. So ask questions early. Ask, and it's okay to ask, but be very cautious of your words that you use once that you do this. Let's see here. Some cultures we've said that. We know that one already. So teen pregnancies, the US, we've always had the high teenage pregnancies rates. So pregnant teens are not known that they may or may not know that they're pregnant, or they may just be in 100% complete denial. You do have to respect the teen's privacy at this age, because even though that they may be a juvenile, depending upon their general age, is once they have this child, they are considered an adult. But at the same time, remember, you have to assess these female patients just like any other potential severe pregnant patient or traumatic issue. But if you don't respect their privacy and their own ability, you're not going to get any answers. So the one, and I like to say, paying it forward is very good at this point, because it helps you going forward. All right, so scene size up. Obviously, we know we're going to take our standard precautions, and y'all know during pregnancy, our standard precautions. Oh, sorry, I was looking at the wrong one. Do sometimes allow us to put a gown on, but it's gloves and eye protection must be used at all times. We know that if this is not your first rodeo, you may be able to handle this pregnancy, but remember that any pregnancy can turn south at any point in time. So the need for additional resources is going to be high. So the earlier you call, the better off you are, and the better outcome you're going to have for your resources to arrive on scene. Knowing what happened, building a basis of what's been going on is a big point to where it you have a better painting of the picture when you get there. Again, I've said before, don't get tunnel vision because it is just a pregnant patient. And I don't mean that in any disrespect. It is just a pregnancy. Women delivered children way before we learned about it. This is not something new to the world. This is something that they've done on their own home births way before our EMT class is learning about this. So we aren't just the first ones to come out here and start doing this. When we start talking about falls and trips and stuff like that, be cautious, because that could also go into damaging of the uterus, and that could put them into pre-labor. If they've said that they felt like they've urinated on their urinated on themselves, or they feel a lot of pressure, you may just have to be like, ma'am, listen, I know your husband's here, but listen, I have to look, because I have a feeling I have to look at your your private parts because I have a feeling that you're fixing to be delivering a child shortly. Is there a potential chance that you are in the, that you missed the chance where your water broke? Do you happen to remember feeling like you urinated on yourself, or you just weren't able to control it and you went to the restroom and didn't really pay attention? Ask those questions. Form general impressions. We know, again, we're going to be building that on our way to the call. We're going to make up those, what information did dispatch give us? What do we see as we arrive? Is this something that we're building off of information at the same time as we pulling in the driveway? What does the general area look like? What's the residence look like? Is this something that's going to happen on the side of the road in the back seat of a car? Those again are building your assessments. So the way that I like to do this is if the patient is able to, hey, how are you doing? Can you tell me what's going on? And they're screaming at you, I'm delivering a baby. Pretty sure their ABCs are pretty, patent, and they're going to be able to handle things. Monitor it. I like to have my patients speak to me at all times. I may not be paying attention to them because I'm doing something else to them or for them, but having them speak to you on a regular basis, even if you're asking dumb questions, what that does is it helps you continue your assessment, and it helps you keep ideas of what's going on, and you're able to do that assessment with really not even paying attention to them. So your primary assessment again here, if you see blood gloss or you walk into the bedroom and you notice there's blood all over the floor, pop your head in there and look into the bathroom. If you happen to see a lot of blood all over the floor, or ask, how long has this been going on? And if they say, for a couple hours, ask them, have you happened to have had a miscarriage? I hate using the word abortion at home because not many people are used to us saying, you had a spontaneous abortion. They're like, no, I didn't. Well, you may have had a miscarriage, and that misterminology we blame ourselves because it's the body still does have spontaneous abortions, and there's nothing that we can do about that. But that term is more aggressive than a miscarriage. If signs of shock are present, obviously control the bleeding. Never, ever, ever, ever pack the vagina. We don't want to do that. We know that that's not what we're supposed to do. You always provide oxygen and keep the patient warm, or patients. If there's now more than one, always keep them warm. But remember your basics on pregnancy, delivering the child, the umbilical cord, tying it off, delivering full delivery of the placenta. That's something that you have to make sure. If you tie it off and clamp it, you do the 3 and 7, 3 inches from the child and then 7 inches from the child, and you clamp in the middle. But never ever let go of the umbilical cord that's towards the female if they haven't delivered the placenta on their own yet. You always want to keep, once you cut that, you want to keep a gentle, slight pressure pulling on it. Now, I'm not trying to jump start and pull a lawnmower, but I want to keep a little bit of gentle pressure on that because eventually you're going to have to do abdominal massages and help deliver that placenta if they can't do it on their own, or the passing of it. Women in the third trimester of pregnancy should be transported lying on their left side when available. Rapid transport for patients when they are hypertensive, if they are having a seizure, have significant bleeding or pain, and they have an altered mental status, because again, now that something big is going on and they're unable to assist and or control it on their own, so they have to have assistance. So our history taken should be the same as in every other patient, except this patient now has a person in them. We have to ask the same questions, build the same report. We aren't changing it at all due to the fact that there's nothing majorly different going on besides them having another person. Same thing, can form a sample when we do, You get your sample, you ask your questions, build your report as best as possible. If there happens to be the presence of meconium, that can indicate that the newborn is in very distress, very much distress. And it is possible for the fetus to have aspirated on the meconium during delivery. So that is very, very careful or very dangerous, and make sure clearly notify when you're doing your assessment that you don't notice that staining around their mouth or their nose. So your secondary assessment is the patient's in labor. The physical examination should be focused on contractions if possible. Keep note of those contractions. When did they happen? How often they happen? And how frequently are they? If at any point you suspect that delivery is intimate, you should check for crowning. You do not deliver a child while you're going down the road. You always stop your ambulance on the side of the road, advise your control, what are you doing, and get into the back of the ambulance to assist your partner. Now, I will tell you, if your partner's like, no, drive, it is very, very unsafe for you to deliver a child while you're going up and down the road. So it is very highly recommended that you stop, park, and provide assistance, because now your one patient is becoming two, and your whomever is in the back is going to need an extra hand. Obtain sets of vitals repeatedly. We know that those are going to go every 10 to 15 minutes. Most likely, if you have them set on a timer from your monitor, it's going to continually to do it without us pushing buttons. Reassessments mainly are to maintain and check your ABCs, because we need to know, are they still patent? Are they able to handle it on their own? And do I need to provide any other assistance? Most likely at this point, you should have regular high flow oxygen on your patient, because that's part of our standard protocols, is that we're going to do this for any patient that we come in contact with that is going to be trained. Now, I'm not saying 15 liters of nasal cannula, 15 liters of non-rebreather on every single patient. But if your patient just needs, 2-3 liters of nasal cannula, that's fine. I guess I should say of oxygen, not high flow oxygen on your patients. So supplying just regular oxygen is okay and should be your standard of care on every single patient that you touch. Again, if delivery is intimate, notify staff at the receiving hospital. Provide an updated status on the woman and the newborn after delivery. And again, it says if delivery does not occur within 30 minutes, provide rapid transport, because now we're getting into a very complicated delivery. Let's see. Continue on our reassessments. If for a pregnant patient with complicated, unrelated to childbirth, be sure to indicate the pregnancy status of your patient on the radio report. What are they doing? Or are you expecting imminent delivery or arrival, or have you had delivery? Your gravida parida is very important. So gravida means how many times the patient has been pregnant. I've always been impregnated, and I don't mean no disrespect for that. And then parida means how many births have they have. So you can have a gravida 5, so that means they've been pregnant 5 times, but they've only had so the GP would be 5, and they can have a parida of 3. So that means they've had 3 live births. So, and it's not to say that that's on that patient or any other issues, but that tells the receiving facility and yourself, well, this lady has had multiple births, so this could be faster than we expecting, or she's had complications of some sort that has required a higher level of treatment. She may have had a stillbirth, a miscarriage, or lost the baby some form of fashion. So that's something that we need to dig into. So you have 6 stages of labor. The 3 stages. Okay. Well, maybe I read that wrong. So on my screen, it says 6 stages, but I'm pretty sure there's only 3. So the 3 stages of labor are dilation of the cervix, delivery of the fetus, and delivery of the placenta. Pretty sure that only happens 3 times. There's no 6 stages there. The first stage begins with the onset of contractions and ends with the cervix is fully dilated. The first stage is usually the longest and lasting an average of 16 hours for the first delivery. That is the first one, period. The onset of labor starts with the contractions of the uterus. Other signs of beginning of labor are showing of the body and a rupture of the amniotic sac. Sorry, that is bloody show, not body. I can't read. So I'll start that over. Other signs of beginning of labor are the bloody show and the rupture of the amniotic sac. The frequency and intensity of contraction in true labor increases with time. So keeping up with that would benefit yourself because that tells you how soon to be that you're to expect a delivery. Labor is generally longer with primitive gravida than in a multitude gravida. A woman may experience premature or false labor, or even called Braxton Hicks contractions. Here is a table on distinguish between true labor and false labor of Braxton Hicks. I'll let you read that for a second. All right. So some women experience a premature rupture of the membrane in which the amniotic sac ruptures too early and the fetus is not delivered or is not ready to be born. The patient may or may not go into labor. You will need to provide supportive care and transport to the facility, so a high dose of diesel or gasoline from your ambulance is much needed when you're transporting these patients. You will need to provide supportive care and transport them to the hospital. And most times towards the end of the 3rd trimester, the head of the fetus normally starts to descend into the woman's pelvic and into the fetus positions for delivery. This movement downward into the pelvis and the sensations that may accompany this descent is called lightening. So lightening of the cervix, lightening of the area happens to occur and things start thinning out. You may notice that the urge to use the restroom is a lot more because of the placement of the children. The second stage of labor begins with the fetus begins when the fetus begins to enter the birth canal and ends with the delivery of the newborn, which is spontaneous delivery. Make a decision about helping the woman to deliver on scene or providing transport to the hospital. Urethra contractions are usually closer together and lasting longer. The perineum will begin to bulge significantly at the top of the fetus's head and should appear at the opening of the vagina, and that's called crowning. So 3rd stage of labor begins with the birth of the newborn and ends with the delivery of the placenta. During this stage, the placenta must completely separate from the uterine wall, and this may take up to 30 minutes after delivery of the child. Again, once you cut the cord, you can, again, it's not something you need to keep hold of it, and apply pressure, because sometimes with some contractions I have seen where they have the cord has been sucked back up into the birth canal, and the reasoning why is because during the I don't want to call it seizure, but during the muscle spasms that the woman's having at the time to try to deliver the placenta may cause the umbilical cord to retract. So keeping hold of that or keeping a slight pressure on that while you finish, suctioning out the baby or, doing things like that. It's not so much as necessary, but again, keep your attention on that, because if during transport, you're going to have to potentially start doing a abdominal massage to help push and deliver that placenta. I have not been able to ever have to do that. I've always been able to deliver the placenta while en route or while at the facility after transport. I've never delivered the placenta on like on scene and done the full birth and then transport. So I delivered my fair share of babies. It's not something to be scared of. It is a beautiful process. It may not be beautiful for your first time, but it is something that is very pretty for the family themselves. Preparing for delivery. Now, so if you say you have to look because there's contractions and all that, and you see crowning, you're fixing to deliver a baby on scene. So that is something that you know that you're like, all right, well, I'm getting ready for this because this isn't happening. So advise dispatch, hey, this is what's going on. Go ahead and roll me another unit. This way we are preparing for delivery. Natural disasters, obviously inclement weather, or other environmental factors make it impossible to reach the hospital. You're going to be having a baby on scene. So preparing for delivery. So what we're going to do here, what I need you to determine what is intimate. Ask the patient some of the following questions. When are you due? Is this your first pregnancy? How long have you been pregnant? Are you having contractions? How far apart and how long are they? Have you ever had spotting or bleeding? Has your water broken? And do you feel the need to have a bowel movement, or do you feel the need to push? Because those are signs that the body is like, I want this out. This is coming out of me, and we're going to make it happen soon. So that being said, is just be prepared to do that imminent birth. Have your OB kit ready, have it useful. If you've never opened up an OB kit, I highly suggest that you do. But when you do it, make sure you take precautions, wear your gloves, do all that other fun stuff, because you're going to have to seal that bag back up, because all of those things are very important to be into that kit. So you just need to be ready and know what's in that kit prior to it's time to say, ready, boys? And you're like, I don't know what I'm doing, because you're going to do that anyway. So don't let that be a problem. Hold on a second. All right. So here, ask the question at the same time. On your previous deliveries, have they happened in the field? Have they been any risk? Are you a smoker, drinker, or use any recreational drugs? Are you a high risk? Because the doctor will tell them they're a high risk. Have you had multiple deliveries? That's nice to know, because you're only thinking you're gonna have one, and now you're fixing to have two. That's pretty important. Ask about prenatal care. Did they have prenatal care for this child? Did they seek a care of a physician during this, or is this something that is an uncared prenatal cared for child? Because that's going to tell you if they're going to be high risk or low risk. If the patient says she is about to deliver and says she may have a bowel movement or feels the need to push, you better get ready. It's coming, because we don't know what the birth is. We're gonna have a baby and we're gonna pick out a name on the way to the facility. Never ever try to hold the patient's leg together. It's not gonna work. Don't worry about it. But do not allow her to go to the bathroom. Don't let her sit on the toilet, because you're gonna hear bloop. Oh, there's a baby. Yes, I tried to tell you that, and you didn't listen. So if they feel that it's time to go to the bathroom, reassure her that the sensation of needing to move her bowels is very normal, and that means she's about to deliver. If your decision is to deliver at scene, remember that you're only assisting the woman with her delivery. We don't have the medicine. We don't have the ability to do those nerve blocks. She's on her own, baby. So we are only there just to help, guide, and support the baby as it's born. We're there just to catch, boys and girls. Here's parts of your OB kit. If you'll look there, you have like the blankets. Here's a little pad. There's the knife to cut the cord. You should have some clasps right here. These are to clamp the cord. You should have 2 of those. So again, knowing what's in your individual company's kits are very important, just so you can prepare yourselves. Position the patient. All the clothing should be removed off the patient. Here, let's go here. This is what I want y'all to see. So this is basically positioning. You want to try to get them in a seated squatting position. We don't have those cool little toys you see on TV, the tools, not toys, where they prop their legs up in the girdles. We don't have that. We're not that high tech yet. I don't think we'll ever be. But at the same time, as we need to make sure that they're positioned correctly, that they have the support. If families around, have them help hold the legs back. We only want to drape the legs to kind of help control things. If they're already completely naked, that's fine, but try to cover their body, just to kind of give them, because they're not really, they don't really care that you're there right now, but they're going to be embarrassed, I promise you. Be prepared. As you can tell, you start to see crowning right here. This imminent delivery. This pad underneath here is to help with any type of fluid that leaks out, because it's going to. So your partner should be at the patient's head to comfort, soothe, and reassure her delivery of the child. Now, again, if there's family there, you're going to want to have your partner there by your side, because you're both going, I don't know what I'm doing, I don't know what I'm doing. Oh my God, oh my God, oh my God. The patient will need oxygen, but them allowing that during that process is going to be the hard. It is common for the patient to become nauseated. Delivery, some may vomit, some may not. I have found just in some random abilities that I've gotten over my time, taking an alcohol pad and put it in at their head or on their chest or something to that, so they can smell it, does help with that. It may not. Continue to check the patient for crowning. If you happen to see it, you'll see it at the prenatal areas. You'll notice the widening of the birth canal, and they'll tell you, oh my God, I'm pushing, and then you're starting to that contracts. They want to push only on contractions. Take a break when the contractions are over, so they can not wear themselves out as much. Remind the patient to take quick, short breaths during the early contractions, but do not strain. Between contraction, encourage the patients to rest, breathe deeply through her mouth. I don't know how much possible that is. My wife had a C-section, so she didn't feel a whole lot. But I've delivered, the ones I've delivered basically will just tell you to shut up. They hear you, but they are not listening to you at all. Skills 34-1 helps with the delivery. That is your book that shows you delivery steps. Delivering the head gets tricky because sometimes you have to be very careful about the shoulder placement, how you need to adjust it, but never ever let go of support of that head. When the head comes out first, have your bulb syringe handy and suction the mouth first and then the nostrils, because babies are mouth breathers. They're not born knowing how to breathe out their nose. That is a learned skill. So that's not something that they're blessed with like we are. Place your sterile gloved hand over the emerging bony parts of the head and can control the delivery with the support of the head. Hold on 1 second again, y'all. All right, back on. So the head's going to start to rotate when we go through this process. So it's because they have to deliver the shoulders. So when we start delivering the shoulders, we have to rotate the body, and that way so we can move and try to get the child delivered. Be careful that you don't poke your fingers into the newborn's eyes and just use, you want to support their head, put their head kind of in the palm of your head. Use that, remember when you're doing CPR, you do the EC method. So you want to put the palm, like their chin's going to rest on the spot between your thumb and your index finger into that C position, and that's how you're going to support them. Unruptured amniotic sacs, usually the sac will rupture at the beginning of labor or during contractions into that period. If it is not ruptured by the time the fetal head is crowning, it's going to look like a pus sac. Is the way that when I first saw it, I was like, what is that? You're like, I don't know. It's gonna like the sac's coming out of the vagina before the child. The sac will start to suffocate the child if it's not been removed. You're gonna have to try to puncture the sac with the clamp. Don't ever use the scalpel. Use the clamp that you use to clamp the cords. You're gonna have to either try to puncture it or grabbing a hold and kind of twisting it and rolling it over the clamp. Now, remember when you do that, you're gonna have a gush of fluid, so be cautious that you don't have any type of aspiration to that child. If you have to, make sure that you rupture it, and then you're gonna have to do a fast delivery so you can suction out that airway. Make sure that it punctures the site this way, as the fetus it won't be happening on the fetus's head, and only do this procedure if the head is coming out. If the sac starts to come out and you notice that and you don't see anything, be cautious. Start keeping an eye in that area. We want to make sure that it's not something else before we try to rupture this, and it's not the amniotic sac, and then we're in trouble even more. So talking about the umbilical cord around the neck. If as soon as you start to see this, use one finger. This is the only time that we're really allowed to put our digits inside the body, is if we notice the head starts to come out and the head is starting to develop. You want to take one finger and just feel quickly around the neck of the child. You may have to stick a gloved finger just barely inside the vagina to check around the neck to make sure that there is no cord. Usually you can slip the cord off very easily if you do notice the cord. Do not cut it at that point, because your and the child is not ready for that to take place. So what we have to do there is, if we reach our finger barely and we feel this, you're going to have to make basically a hook out of your finger and grab the cord and pull it out and over over the child's head. Sometimes that happens pretty easy, and then sometimes you will have it to where it's formed into a very tight anchor around the child's neck. And to those situations, it gets a little bit rougher when you have to worry about those that are tight around the neck, because you need to be cautious and not have suffocation to the child, or and I say there will be a time that at this point that you may have to cut and clamp the cord, but you're going to clamp it on both sides and then cut it, but you're going to have to have extra help. This is not something you're going to be able to do by yourself. You're going to have multiple parties down there helping you. So you'll have a couple of sets of hands if that's where you have a tangled cord. The head is the largest part of this body. This child, we know that all of our heads are pretty big when we're born. Support the head and the upper body as the shoulders deliver. Don't try to pull this baby, because you're causing undue stress upon the neck and to the spinal cord. So let's not do that. Remember, these are slippery little footballs. So be mindful of that. If you have to use a blanket that's on your ambulance due to the cold weather that now we're all getting into, make sure that you have your supplies at least handy. If you have to use a shirt or other clothing material, make sure you do that, but let's hurry up and dry that baby and get them the slipperiness and I hate to say this, but it's called the vernix cassia. That is the cheesy white substance that is covering these babies. You need to dry them off, get that off of them, and that's okay. But let's not leave that on them because we need to remove that, and we can do stimulation as we're doing that to try to get this baby to breathe on their own once you've suctioned the airway and all that. So be cautious and be very don't try to grab this baby and stand up. Stay low to the ground or stay on top of your stretcher, and just delivering this baby and laying it on the stretcher is okay while you try to clean this newborn up. If the mother is willing and able to, she needs to have skin to skin contact. That's why I like for the mother to be I don't want it to sound bad, but they need to be topless because it's as soon as this baby's born, you need to suction that airway, get everything clean, start cleaning them off, and lay them chest to chest. These babies have that warmth, that stimulation is brought by the smell of the mother, the heartbeat. They can hear that, they can feel everything, the body moving, the respirations. So these babies do try to start calming down a lot faster. So that skin to skin contact is very, very important. Wrap the newborn baby up in a clean blanket and or towel because they will lose their heat very, very rapidly. If you have the ability and your kit comes with a little toboggan, cover this baby's head up as much as you can. They needs to make sure that head stays covered. Try your best to keep the baby in a neutral position, but sometimes they just don't. They do what they want to do. Again, here where it says wipe the mouth with a sterile gauze pad is needed. Well, you're going to have 4x4s galore in your truck. If you need to use multiple 4x4s, man, that's fine. Just clean that baby up. We don't want any of the fluids, the cottage cheese. We don't want any of that into the baby's mouth and going in down into the respiratory system. As you see there, cut and clamp the cord approximately 60 seconds after delivery. It can be a tad bit longer, but remember when you get ready to do this, you're also going to have a large amount of blood because of that blood cord. That cord blood is going to be a dark, rich blood. So don't be mentally prepared for that. It is not a quick snap, pull, snip. It takes you. Sometimes you may have to grab your knife, not your knife, but your provided scissors and or surgical knife, and it's you have to cut to make that happen. The hospital is gonna ask you for a 1-minute Apgar score. If you're not familiar with how to do a 1-minute Apgar score, I highly recommend it. In your book, I know that there's a chart in there on how to perform that. That is something it can be tested upon National Registry too. So make sure you overview that. I don't know if it's in this chapter, but having that idea of what the Apgar score is going to help you in long-term care for that child. Again, delivering of the placenta is not something that is on us, but we have to assist into that. And the hospital is going to want every bit of that placenta. They're going to want to look at it, inspect it, and blah, 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 blah. And most of your OB kits do have bags that are provided in there, so you can put it all in there and transport it with delivery. Sometimes they are pretty rapid at that because they've had contractions and all such as they're getting ready, and this placenta is already weakened. So when it is time, you may deliver those pretty rapid, but a lot of times it could be up to 30 minutes. Like I said, I haven't had the ability. I know several medics myself that I know personally have delivered placentas in the field. It's not uncommon, but at the same time as I haven't been blessed with that ability yet. So I guess I can say I'm okay with that. I don't really know. After the delivery of the placenta and before transport, Place a clean, sterile, sanitary napkin over the vagina and straighten the woman's legs up. Try to keep them comfortable as you can. You will notice some bleeding, and what we're trying to do is with that napkin is try to help control the bleeding. If you have the time and you're able to, you can do a gentle massage on the abdomen, and you want to do it in a circular motion. Tell the female what you're doing and why you're doing it, and what you're trying to do is help to stimulate the blood to coagulate and to slow that bleeding process. It's a abdomen massage. You do it firm, circular, kneading motion with one hand cupped over the top of the fundus and over the pelvic bone. That doesn't really sound a whole lot of comfortable, but it's just like we're trying to assess the quadrants of the abdomen, but we're going to make sure that we do it in a circular motion. I'm not trying to push from the belly button to the back of the pelvic bone, but I want to do a firm circular motion massage. I guess that's the easiest way to see it, and it don't matter if you do counterclockwise, clockwise. I've never heard it to be of any concern of which one. We talked about the placenta and delivery. We'll cover this next little bit and we'll take a break. For the first minute of life, performing the following initial steps in the newborn is very important. Making sure their airway is open and in suctions, keeping them dry, warm, and you do the tactile stimulation, touching their feet, moving their hands. They're making sure that they're breathing adequately and breathing on their own. Normally, a newborn will begin breathing 30 seconds after birth. That's normally. Their rates should be above 100. Many newborns do require some form of stimulation that will require them to breathe and begin circulating blood through their lungs, including positioning the airway into the neutral position or sniffing and the sniffing position. If necessary, then suction the mouth and then the nose. Vigorously dry the head, the body, the back. Rub the newborn's back and generally pat the soles of his or her feet. And that'll be tactile stimulation. If signs of good tone and adequate ventilation are not present after performing the initial steps for 30 seconds, then positive pressure ventilation with a mask may be necessary. So at this point, you would want to take a neonatal bag valve mask, hook it up to supplemental oxygen, place it in front of them, and let it flow. And the reason why I say a BVM is because if they don't go any further, you're going to have to start CPR. But you have already started the process and you're ahead of the game because now you have the BVM already out and prepared. Here's how we start our resuscitations for our newborns. It's just like your CPR. I'm not going to cover that. You've already done CPR. You should have had it. If not, we know that you need it or you talked about it in boot camp. So observe the newborn for a spontaneous respiration, skin color, and movement of their extremities. The tactile stimulation that you provide is to get them to doing it on their own, to breathe on their own, to function on their own. And that reminds them, like, remember, that's all been a non-voluntary process. They haven't had to stimulate their body to go. The cord has been responsible for all of that. So that's something that is new to them. Their body is starting off from a cold reboot and they're building life at this point. They are learning by the millisecond on what their body's to do. If chest compressions are required, use the hand circling technique. It is just like doing CPR when you do in class, when you were doing the infant CPR. One person holds the bag valve mask, the other one does the cupping position. Their hands go on the back end of the side, and you do CPR with your thumbs. Again, we talked about the meconium staining. If the meconium staining, if you see meconium staining in the amniotic fluid, the meconium staining and the newborn is not breathing adequately, consider suctioning the newborn's mouth, then nose after delivering and before providing rescue ventilations. And the reason why is because I don't want that feces to go further into their lungs, because it's going to make that little body sick as can be. So if we can provide those abilities and get them cleaner oxygen, then let's do that. Let's make sure we get them clean as possible, and then we can provide ventilations. Because if we do it the right way, they should not have any meconium staining once we notice it. Now, again, that being the case, we can't prevent that from happening. So that's not something that is our fault, if y'all follow me. We just have to make sure that it's done, it's taken care of, and we do, once we recognize it, we fix the problem. Let's see here. We'll talk about the Apgar score. Let's take 10 minutes real quick. We'll be back. I don't know. I'll tell you what, I'll see y'all at 5 after 8. I need to run and make sure something's put up real quick downstairs. So 5 minutes after 8, we'll be back on here and we'll continue going. And that should cover the rest of the evening. So give us just a minute. Yes. How's that? Is it better?
No. Yeah.
Thank you, Rebecca. All right. So yeah, 20 more slides left, and we'll be moving right along. All right. So on the Apgar, so the Apgar is very important because a lot of your OBGY, I mean not your OB, but your receiving facilities go off of your Apgar to determine how the child's doing, what is their delivery status, are they in need of anything. So it is rated between 0 to 2 in 5 different areas. So you have your appearance, your pulse, your grimace or irritability, activity or muscle tone, and respirations. So those are the different levels. You come here, there's a chart coming up. So the total of 5 numbers is the Apgar scale. Calculate the Apgar 1 minute and then 5 minutes after birth. The highest that they can get is a 10. So here is our score. So you can get a 0, 1, or 2 into those areas. So you start with appearance, or the body is pink, but hands and feet remain blue. So that would be a 1. And you trickle back down through here. But again, that's 2, 4, 6, 8, 10. So they got 2s all the way down here. And a lot of time your OB nurses that do this so much, they can look at it and like when you bring a child in, you're like, oh no, they were a 10 when they were born. You're like, then why is he pink and has slow respirations? And it's not that they're being disrespectful. It's just you got to think that's all they do is deliver babies. So they know what they're doing. That's like I had a particular person argue with me on how to start IVs. And I'm like, on my side job, when I'm at home, I work at a clinic, and that's all I do is IVs and injections. Like I can probably start 30 IVs a day. So it's like, I'm not saying my skill is the best, because I've missed some and couldn't gotten some. But it's like, come on, these nurses know the score. That is very high point for them. So I don't expect you guys to know this, but at the same time, as make sure you have a cheat sheet that you're able to use and work throughout your day, because those cheat sheets and those books that you can have it's a benefit for you. Steps for assessing the newborn. So what I want you to do is quickly calculate the Apgar score and write it down, because you're probably going to forget over time. Stimulation should result in immediate increase in respiratory rate. So if they're sluggish and you start rubbing on their feet or patting the bottom of their feet, that should stimulate them to cry. That should make them like stutter, like that. And then the pulse rate should be at least about 100. If not, start your bag valve mask ventilations. Reassess respirations about every 30 seconds because it's taking majority of your time. So that's why I say if this child is in need of support, you're going to need additional resources. One person takes care of the child, one person takes care of the mother because they're both very important. And when you separate them, the mother's not going to do well, I can promise. Assist the newborn's oxygen via the pulse ox if you have the ability to do that. Sometimes you can take it right above on the right wrist, and that is helping to form the over central cyanosis. So if it works, it works. If it doesn't, it's okay. Request a second unit as possible because you, like I just said, I just went over that. I'm not going to talk about that again. All right, so a breech delivery is when this baby says, you know what, I ain't doing it, and they're going to try to come out butt first. Most infants are born head first, and that is called a Varix presentation. Occasionally, the buttocks are delivered first, and that is a breech presentation, and that's where we are at right here. They are breeched. They're not going to, you can't turn them around. They have to get pulled out through surgery, so it's just not happening. Breech deliveries usually do take very much. They are very long. And you're gonna have to. That's gonna require transportation. However, if the buttocks has already passed through the vagina, the delivery has begun, and it's a complicated delivery. But you're gonna have to deliver this baby in the field. So the way that you do this is you're gonna prepare the same normal position, the same kit. And the legs need to dangle on either side of your arm when you start to catch this football, but it's in reverse. So you want it to deliver legs on one side, legs on the right, legs on the left of one side of your arm. I'm right-handed, so I would put my hand at the base of the vagina and tell them, listen, ma'am, I'm going to have to deliver a little different, and we're going to manipulate him or her a little different way. We have to tilt down, do the shoulder, but I'm going to support everything here. And what I'm going to do is once he's out, I'm going to lay him directly on your chest. And I need to work with him on your chest. So then go that route. Instead of trying to hold the head initially, now we're going to catch it and let him come out with his butt first. He's coming out that way, so you know he should be a little turd the rest of his life. I'm just kidding. I always joke about that. If they're born butt first, you know how they're going to be. So the head is the most face down, should be allowed to deliver spontaneous. So what you want to do is take your middle fingers and spread them. Do the old Spock method if I'm showing my age there, and make a V. So what you want to do is position that V at the base of the vagina to keep the walls of the vagina from compressing the fetus's face away. And that's not really what we want to make sure that their airway is open, and you're going to have to suction them as close as soon as their head comes out. You need to suction the mouth and then the nostrils right there at the base of the vagina, because you're trying to clear it and their body is already getting that tactile stimulation. And they're starting to try to gasp because their body's feeling that rush of cold air. And it's like, oh God, what is that? And they're not ready to take a deep breath because they know that amniotic fluid's still around them. But if we can clean it and remove it, and as soon as they come out, suction that mouth, then the nose. Like Joseph is saying, live long and prosper, because now their butts are coming out. But we've got them. We're going to take care of them. So now we have a very complicated here, and this is rare. You may have a single arm or a single leg, and that is a limb presentation. That's no other way. This baby does have a extremely long left leg. That is rare, and I'm pretty sure everybody in this party is going to be like, what is that? Why is there a leg right there? Oh, what is this? It's not normal. We don't see those all the time. If they've had prenatal care, and the doctor should know that they are not turned, and that's why we don't see these as much, because that these are taken and they're seen in the pre-hospital cares, and they know that this baby has not been turned, and they're going to try to move them into a facility faster than later. And maybe you see in this because they are just stubborn and they don't want to go to the facility in time. And then when it is past time, this is how you're going to meet them.
Oh, yes, surgery is going to be needed here. You can transport immediately, do supportive care. You can go license sirens to the hospital because that is life, limb, or safety. Never, don't do this. Don't push it in or don't try to pull it out because if you touch it, it's like tickling their feet. They don't like it. They'll move it back. That's not. We don't want to do that. Don't try to tickle them. It's not cool. So a prolapse cord. These are one of the ones that start to get. This is probably the most dangerous that we're gonna see. Prolapse is where the umbilical cord comes out of the vagina before the fetus does. This has to be treated in the facility. This is where it starts to get a little trickier. I don't want you to put your push it back into the vagina, but your job is just to keep the fetus's head off of compressing the cord. Now, this is where I hope none of us ever has to do this, but carefully insert your gloved hand into the vagina and gently push the fetus's head away from the umbilical cord. You're going to be transporting this woman with your hand between her legs, holding this child's head up. Now, it's not going to be the prettiest thing in the world, and you tell her, hey, this is what's supposed to happen. Remember, try to keep that cord moistened. Don't let it dry out. Try to wrap the cord if possible. Apply high flow oxygen. If you can, right here where it says, try to place elevate her hips elevated or in the knee chest position. You want to try to get her hips as high as possible in a safe manner because you don't want the body you need to take pressure off of it. And that's the best way that they want you to do it. Some Spina Bifida, that is a defect that it's a portion of the spinal cord or meninges may protrude outside of the vertebrae and possibly outside of the body. Maintenance of the newborn is to control the temperature. Apply moist dressings because the moisture can lower the newborn's body temperature. Multiple gestations. Twins can occur about once in every 30 births. Twins are usually smaller than single fetuses, and deliver is typically not difficult because they're so small. You can go up to 10 minutes, and then the max we've seen and we talk about here is about 45 minutes. Most of the time, they're about 10 minutes apart. You have some that are, instantly like boom, boom. The process for delivering twins is the same. We're going to have the same exact process, the cords, the cutting. You're going to use 2 of everything. So, and the parents should know that there's twins. If not, you're both going to be surprised because there's 2. Most of the time, your newborns deliver about 8 months, 36 weeks, and they weigh less than 5 pounds at birth. So that's going to be your difference. Now, if you look at these pictures, these are twins. You can see one's bigger than the other. Premature newborns on the right are smaller and thinner than full-born. So obviously these are not twins. You can just say this is a preemie. That's a full-term baby right there. I will tell you, generally, they do not like to take white males earlier than 36 weeks because they do not form the surfactant into the lungs. So the body does not produce the surfactant enough for young little white males before 36 weeks. So if they have to deliver this, let's say this little boy right here is delivered at 34 weeks, they will actually spray surfactant in his nose at birth to help stimulate that surfactant, natural surfactant growth into the lungs, so his lungs do not stick to his ribs. So that's a pretty neat little thing. Premature newborns require special care to survive. Most of the time, except when they're about a pound, those are the ones that we start to have issues there. The preemie newborns. I've delivered twins, and I've delivered a preemie. He was literally able to fit in the palm of my hand. I transported him to the hospital. He did survive, and he's lived long and prosperous. He's still a good little kid.
I do still try to keep up with them. That was my very first delivery 20 years ago. So it makes me feel old. Pregnancies lasted than 41 weeks. Those are going to be your hospital-based deliveries. Post-term fetuses can be longer, sometimes weighing 10 pounds or more. We do not want those into the field. They need to go to the hospital. Samantha, I have twins. They're both preemies, 2-1, 2-2. Wow, there's some little bitty old things. They like peanuts. They little. Let's see here. Post-term, you are going to have more stress to these. You are going to have potential more injuries to the mother and to the child. So be careful. I weighed, number one, weighed 4 ounces, born 3 months. Woo wee. That's little. 1 pound, 4 ounces, born 3 months early. Wow, that's awesome. Let's see here. Fetal diminished is the onset of labor premature, but skipping that one. Postpartum is real. It is 100% scary. My wife we had our daughter 2 days later. She was admitted back into cardiac ICU. She had cardiac myopathy, swelling of the heart and fluid around the heart after childbirth. We don't know what caused it, what happened, no nothing, but they're telling me that my wife was potentially fixing to have open heart surgery, and we have like this 3-day-old baby, and I'm in the ER with this. My wife looked like a freaking balloon. She was so full of fluid. It was scary. So postpartum at the same time is the best way that I can explain it. Ladies, I'm giving you all the open floor. Please, if you have some more information, because I'm speaking from the male version. But it is basically, guys, these females have these overdumped fluids. They have all these levels of estrogen, testosterone, all these hormones built up. And then in the delivery of the baby, that's all taken away. And because of the delivery of the child, everything's hopefully healthy and they can have postpartum because after the fact. So you have that mass reduction and there's no way to help that. So you have all of this postpartum issues. You deal with depression, anxiety, all that wrapped up into one. It can be very dangerous for the mother of the newborn and the newborn itself to go through this postpartum. I've known mothers that weeped for days and days and weeks, didn't know why. Anytime the baby cried, they rushed out in tears. They thought that they were horrible mothers. They had the lactation stimulation. They could hear a baby cry that wasn't theirs and they would lactate. That was part of the postpartum issues for some of the ladies that I knew. Some were upset because they could not produce milk for their own child. Postpartum is something that is very, it's hard to deal with, not only just besides the physical part that they're talking about on screen. I think more of postpartum needs to be addressed in EMS when we deal with them going into the hospital and not having, because so I look at this right here, y'all. Let's look at this screen. So this is just normal controlling of bleeding. We can fix that. We know how to stop the bleeding and control it. We don't know how to stop the postpartum that we normally see and normally hear about. That's not something we deal with. We're gonna pad the vagina if there's massive amounts of bleeding. That's something we can't control. That's out of our realm, but it's our job to try to slow it down until we get to a facility. We're never going to go faster than where we're comfortable on the way to the hospital, because remember, your patient is now 2, and you have to make sure the safety of those 2 upon delivery to the hospital. You don't have that newborn child safety seat that you can lock them up in because you just delivered it on the middle of I-10, if y'all know the corridors there. And you just delivered this baby on the middle of I-10 highway, and now you're transporting to the hospital. So
Be cautious of that when you take these babies and you take a call for a childbirth. Is it active? The contractions are, how far apart the contractions are controlled. Those are questions you just want to know. If they can't answer them to, and you're just like, God, why can't they just answer a question? Trust me, I've been there. But again, dispatch is only told what they were told. That's it. They don't know anything. So that's the end of the class for this evening. I know I went over and over a ton of crap. I know it has. But some things I wanted to address with y'all real quick. We are, I think Tuesday is our last class. Remember the final is coming up, and that encompasses everything that we've done in this entire lecture, this entire course. I know I've probably bored y'all some with some information. I've probably given y'all information dump of stuff, and then sometimes, like certainly with the words, I didn't do so well. We are probably going to talk more about the final the closer we get to it, and then we're going to talk long in depth about National Registry and what can we do to help you guys get there. What can you do to help yourself get there? But for this evening, I'm going to let y'all enjoy it. Here's your class code for the night. It is at 90?23. That is your course code. Good luck on your test. Several of y'all have reached out to me. I hope I have answered everybody's information. Traveling has been bad. It was a 3-hour flight instead of a normal hour and 45-minute flight because of weather. So, and then I'm locked out of my company's computer because it says my contract ended, but I'm still here. So obviously it hasn't. I'm going to mute my mic and step off to the side. If you guys need anything, give me a minute to unmute the mic and I will get back with y'all. But other than that, folks, I hope y'all have a fantastic evening, and please reach out to me on Discord or by email if y'all need anything else. Other than that, deuces, y'all.
Appreciate it, Chris.
Does the exam close tonight? Caesar, Kobe, you too, brother. I'm sorry. Caesar, I think the exam has already closed. I have to open the JB Learning. Can somebody else answer that? Because on the time of when it opened or closed. Caesar, I actually think you missed 2 classes or missed 2 exams. To be honest, I think I looked a little bit earlier.
Oh, I had no idea, to be honest. I thought I'd been caught up on everything. Let me go in and check because I think I might have checked Sunday, thinking that I may have gotten confused, but I'll check it out in a second.
It's okay. I mean, it's not something, I get it. Again, you and I've talked before, so I know things are going on also. So life's getting busy. We all are getting super busy. Let me see if I can stop sharing this and actually go to JB on my screen.
Yeah, I thought it was open till tonight.
Yeah,
Right.
don't quote me, y'all. Don't quote me. I'm just saying I thought.
You're fine.
All right. So that's not what I wanted. So mod 4 closes tonight at midnight. That is correct. Sorry, Caesar. I do show that you're missing that one. Mod 4 and chapter 32. Several of you guys that may have still be here or left still owe me 2 tests.
All right. do I need to reach out to you through Discord and maybe talk about being able to work something over both of those?
Yeah, just shoot me a message. That's fine.
All right, I appreciate it, Chris.
Hey,
Have a good one.
Leah, you too, buddy. Leah, if you're still listening and are here, you owe me module 4 exam. So just thought I'd let you know. I see your face on here.
I'm going to work on getting mine done tonight too, Chris. I just need 32 reopened as well.
Roger that, sir. Yeah, let me check onto that. Why that did not have to take place. I saw your message as I was talking to the other ones, but I don't know. Let me. Oh, Joseph, 2 seconds and it'll be situated.
Okay, thanks, man. I appreciate it.
Roger that, brother. Rebecca, you good? I don't know if the other 3 are still here or need anything. You got everything you need?
Yep, I'm good.
All right. Y'all have a good night. Enjoy yourselves. Good luck on your test.
Thanks.
Thank you, Leah. I just saw your message. I appreciate you.